Welcome back to the Doctor is In television program. I'm Dr. David Morwood. I am a board-certified plastic surgeon right here on the beautiful Central Coast of California. I'm delighted you could be here with us, and I'm delighted to welcome on as a guest Dr. Daniel Luba, gastroenterologist, very esteemed guest. Dr. Luba, thanks very much for joining us.
Thank you for having me.
Dr. Luba, I am delighted you're here. I'm so interested in learning more about gastroenterology and colonoscopy and EGDs and what a week is typically like for a gastroenterologist. And then we're going to segue into colon cancer, which I know you are an expert in and you can teach us a lot. So let's get started a little bit. Tell us about yourself. Let's start with where you grew up and you went to high school, and then where'd you go to college and medical school, etc. Tell us about yourself.
So I grew up in New York, and then I went to college, but sort of different from most people, I went to a 6-year medical program. So from high school, I applied to this program, and I got accepted to both college and medical school at the same time.
So you're a boy wonder.
Well, I just got lucky and got into a shorter program.
So where in New York, Dr. Luba?
A place called New City, New York. It's just north of the city.
Just north of the city. I'm blessed and lucky enough. I started my training at Beth Israel and Mount Sinai before I headed to Paris and London and Los Angeles and then to Monterey. So where did you go to medical school?
At Boston University.
At BU. So that was a combined program.
Right.
So you went from high school to a 6-year program, combined college and medical school.
Correct.
And then where from there?
And then I did my residency at the Boston VA and then my fellowship at Stanford.
Okay, excellent. So your fellowship, so I want to teach our audience that, so when we say residency, that's sort of like, well, those are the years right after internship or after medical school. And then your fellowship, that was a subspecialty, correct?
Correct.
So your residency was in gastroenterology.
Residency was in internal medicine.
Of course. So you were fully trained in internal medicine. So you could have opened an office. Hello, I'm Dr. David Morwood. And they know who I am. They know I'm Dr. David Morwood. So you could have gone on to be an internal medicine doctor.
Correct.
But instead you went on to gastroenterology and specialized.
Yes.
So tell us what your typical week is like. What is your week as a gastroenterologist like?
Well, as a gastroenterologist, one of the things that's really I enjoy the most about it is that it's very varied. So I see patients in my office and we'll evaluate them and try to figure out what's going on, make diagnoses, treat their different GI problems. I also cover the hospital, so I'll see emergencies in the hospital if people come in for something that requires hospitalization. I also do procedures where we'll do colonoscopies, upper endoscopies, things like that. And then in addition, because I'm in private practice, I manage my practice as well. So there's a very varied, there's a lot of variation to the practice.
And Dr. Luba, you're an incredibly accomplished person, and I just want to give a little hint. Our next segment, and I'm hoping you're going to have time to stay for another segment, you have a project going on related to the genetics and DNA of colon cancer. Mm-hmm. And that's a project that you've invested a lot of your own energy into, and we're going to be able to talk about that next segment. I hope you have time to stay.
Sure.
So a big topic in the news now is cancer, and can we prevent cancer, and how do we get cancer, and I think maybe heart disease is the most common killer of adult Americans, but cancer I think is number 2. So let's talk about something like cancers of the GI tract. They seem to be relatively common, unlike, let's say, a primary bone cancer, or fortunately brain tumors are not that common. But it seems like everyone knows somebody who's gotten colon cancer or maybe an esophageal cancer. What is it about maybe the lining of the GI tract and the oral pharyngeal digestive tract? What is it about that lining that is susceptible to cancer? Why do gastroenterologists see so much cancer?
It's a real good question. It's hard to know for sure what all the cancers are, but certainly there's environmental factors, the GI tract, the lining turns over. It reproduces itself very, very quickly. So with the constant replication of the cells in the GI tract, it makes it, it's prone to making errors. And if you make errors when the cells divide and reproduce, then there's a better chance of having a tumor. Plus, it's being exposed to things in the environment all the time. And some of the things that it gets exposed to are not the best things for the cells. So I think when you look at environmental factors, the fact that it turns over so quickly and so frequently probably puts it at a little bit more risk. The brain, for example, is relatively protected.
Right. Well, Dr. Luba, in my specialty, plastic and reconstructive surgery, we know that chronic inflammation over the course of many years will lead to a higher incidence of degenerating cells, which can become cancerous. For example, a person who bakes in the sun, although it may feel great, those UV rays coming really cause chronic inflammation. Mm-hmm. We know that smoking, a chronic irritant to the lung and to the bronchioles, can cause lung cancer. Now, is there an equivalent in the GI tract where chronic inflammation can lead to degenerating cells, which leads to cancer?
Sure, and actually there are several, but in the colon, there's ulcerative colitis and Crohn's disease, where there's a chronic inflammatory state, and then because of the inflammation, it predisposes to cancer. And in the upper GI tract, if you have chronic reflux, people can sometimes get what's called Barrett's, where the lining of the esophagus starts to change and look more like the lining of the small intestine. And in some ways, that's a protective change because the small intestine is more used to seeing acid, whereas the esophagus shouldn't. It also predisposes to developing cancer.
Okay, so I think that's important to emphasize that there are conditions that lead to chronic inflammation, say chronic reflux or ulcerative colitis, or maybe gastritis, hyperacidity in the stomach, leading to chronic inflammation of the lining that can predispose someone to carcinoma. But Dr. Luba, in terms of public health, this is a key lesson, I think, or take-home lesson. When those issues and conditions are treated, isn't it true that we can almost eliminate the increased incidence of cancers developing?
Sure, and if you look at gastric cancer, stomach cancer, where that, especially in Asia, was caused by the H. pylori bacteria. If we treat the H. pylori, the H. pylori bacteria causes a chronic gastritis, so chronic inflammation in the stomach. If we treat and get rid of that bacteria, we can decrease the risk of getting gastric cancer.
Okay, now see, that's fascinating to me. So let's take a couple minutes to digress. Let's teach our audience what we mean by that. H. pylori and an H. pylori infection leading to gastritis or an ulcer. Let's teach the audience what we mean by that.
So H. pylori is a bacteria. It's lined the GI tract, or the stomach specifically, for ages. It's typically found in countries with poorer sanitation. So if you go, before the sanitation got much better, almost everybody was infected with this bacteria. And we didn't even really think there was much to it. As our sanitation has gotten better, it's decreased in the incidence. So in the United States, we don't see it as much. Maybe about 20% to 15 to 20% of people our age in the United States would be infected with the H. pylori bacteria, whereas, 30 years ago, that might have been 70 or 80%. If you go to Mexico, probably about 80 to 85% of people are infected, and it's also very common in Asia. And especially in Asia there, because of that infection, that low-grade bacterial infection that's just sort of chronic, it can predispose to ulcers, and it can also predispose to cancer.
Okay, so, and I want to emphasize that it's treatable, right? Or can we say it's curable? I mean, that can be treated.
Well, usually you get it when you're very young, and usually it stays with you all your life. If you get treated with antibiotics, it can get rid of the bacteria, and then it's cured. Now, so you eliminate that risk factor.
Okay, now are there signs or symptoms? Like, how would someone know if they have the contamination or infection of H. pylori?
Well, oftentimes they'll have not so much the problem of the infection with the bacteria itself, but it's the problems that the infection can cause. So if you get pain in your stomach, burning pain, ulcers, things like that, the H. pylori bacteria infection predisposes you to getting ulcers. So if you have an ulcer or ulcer symptoms, then you can get tested.
Okay, that's key. So if someone has frequent reflux, dyspepsia, or heartburn, if someone has symptoms of an ulcer, pain in their stomach that goes on for a while, I think one of the take-home lessons is get it worked up, see your doctor.
Right, and one of the standard things to do early on, especially for pain in the stomach, is to check and see if you have that bacteria, because if we treat the bacteria, the pain oftentimes goes away.
Excellent. Okay, so Dr. Luba, that's the upper GI tract, the esophagus and the stomach. Now, we talked briefly about conditions like ulcerative colitis, Crohn's disease, chronic inflammatory conditions that can predispose to chronic inflammation, that may predispose a patient to forming polyps or even colon cancer. Isn't that true?
Mm-hmm.
So what are some of the signs or symptoms that a person may have one of those conditions, like ulcerative colitis or Crohn's disease, etc.?
So for ulcerative colitis and Crohn's disease, the typical thing that people have is diarrhea. And oftentimes there's blood associated with it. So it's usually fairly obvious that there's something wrong. Everybody gets diarrhea on occasion. That happens. But when the diarrhea lasts for more than a week, 10 days, certainly 2 weeks, there's something wrong. And then you start looking and saying, what else is going on here? If you have a bout of diarrhea, lasts a couple days, goes away, that just happens.
Okay, so which is a perfect segue into my next question. When we say see your doctor or see your gastroenterologist, probably for most adults, if they have symptoms of diarrhea, chronic inflammation, bleeding, etc., probably they're going to get a recommendation to get a colonoscopy.
Mm-hmm.
So teach us really what colonoscopy is, how is it done, what are you looking for, the mechanics of it. Do they have to stay in the hospital? Is it outpatient? Does insurance cover it? How long does it take? So teach us about colonoscopy. Give us an introduction, please.
So colonoscopy is basically a way to look at the colon. So we use a scope. It's about the size of my pinky. It's flexible, bends around corners, has a camera at the end of it, and projects a picture up onto a TV screen. So to prepare for a colonoscopy, basically a person has to be on clear liquids the day before the procedure. So a clear liquid is anything you hold to the light and see through. So like tea, broth, apple juice, lemonade, you hold it to the light, you can see through it, that's fine. But stuff like milk or orange juice, you hold it to the light, you can't see through it, that's no good. So clear liquids the day before. In the early evening, you drink the first part of your prep that will give you diarrhea and clean you out so we can see. Now, the second part of it is that the next morning you have to drink another part of the prep. And it's real important to split the dose, and we found that out over the last 10 years or so, because oftentimes we were getting kind of poor preps in the right side of the colon. And what happens is the small intestine during the evening makes this thick, sticky substance called chyme, and that coats the right side of the colon. So it's that second morning dose of the prep that gets rid of that and enables us to see the subtle polyps.
Okay, so Dr. Liu, I just want to make a teaching point for one moment. When you say the right side of the colon, we know that it's the esophagus, goes to the stomach pouch. There's an actual anatomic structure, the stomach, which becomes the small intestine, and there's 3 parts to the small intestine, right? It's the duodenum, the jejunum, and the ileum. Medical school is some years away, Dr. Luba. And then we get to the colon, right, the cecum. And so when you say the right part of the colon, that's the ascending colon, correct?
Yeah, the cecum and ascending colon.
Okay.
So if you just think about your body, right? The right side of the colon is right here. The transverse colon goes here. And then you have the descending colon going down the left side, and then the sigmoid colon into the rectum. Okay. So it just comes up across your body like that.
Okay. So when you perform a colonoscopy, you aren't just looking at the sigmoid colon sort of like the old straight scopes, like the old sigmoidoscopy. You have a flexible, like a little telescope, like you said, is the diameter of your small finger, and you're looking throughout the entire colon,
Right.
right into the cecum. Is that true?
Right. And oftentimes getting into the small intestine in short ways.
Okay, so that's important for people to know. So they need to be prepped. And is the colonoscopy done while they're awake? Are they sleepy time, daydream? Are they under general anesthetic?
So we don't do it under general anesthesia usually, but they are asleep. They're usually asleep. And the vast majority of the people do not remember the procedure after they wake up, which is real important because we want this to be as comfortable as possible, because it should be a good experience for them. Because if there are polyps, we're going to have them come back in a few years to do this again, because they'll be at higher risk of getting subsequent polyps. So we want to make it as comfortable as possible.
Okay. Dr. Luba, do you have time to stay for the next segment?
I do.
Okay, great. So we're going to take a little break, but before we do that, I want to make sure it's important that we give out contact information if someone feels like they're due for a colonoscopy or who've never had a colonoscopy, or they're having upper GI problems such as burning or reflux, or gastritis or ulcers. Let's give them a contact number. Dr. Dan Luba, gastroenterologist, you're here in Monterey County, right? Can we give out a website or a number?
So we're gastroenterology consultants, and our phone number is 831-375-3577.
Okay, I want to repeat that. Gastroenterology consultants, and the number is 831-375
3577.
3577. Dr. Dan Luba, gastroenterologist here in Monterey County. Please stay with us. We're going to take a very brief pause for good cause. Once again, this is the Doctor Is In television program. I'm Dr. David Morwood. We're coming back with the very important, illustrious guest, Dr. Dan Luba. I hope you'll stay with us. We're coming right back. Hello, I'm Dr. David Morwood. I have over 25 years experience in plastic surgery. Here in California, we all love the outdoors. Golf, tennis, going to the beach. However, the sun can play havoc with the delicate skin on the back of the hands and neck. Call or click today to learn the newest methods for restoration and beautification of the hands, neck, and other areas affected by the sun. Hello, I'm Dr. David Morwood. I have over 25 years experience in plastic surgery. One of the common goals I share with my patients is that they look natural after their facial rejuvenation.
Dr. Morwood made me feel really comfortable. His staff is phenomenal. Going into his office is always a great experience.
Call or click today to learn how our combined approach of art and science can enhance your natural beauty. Hello, I'm Dr. David Morwood. I have over 25 years experience in plastic surgery. A smooth, firm neckline is a universal sign of beauty in both women and men.
Dr. Morwood not only helped me regain my confidence, he helped me achieve the best version of me.
Call or click today to learn how the natural neck lift can rejuvenate your beautiful neck and jawline. Welcome back to the Doctor Is In television program. I'm Dr. David Morwood. I'm a board-certified plastic surgeon right here in the beautiful Monterey Peninsula, California, Central Coast. I'm delighted you could be here, and I'm delighted to continue to speak with our illustrious guest, Dr. Dan Luba, gastroenterologist. One more time as we get started, I want to give out a website or a phone number, because we've been talking about colonoscopy, we've been talking about upper GI problems, lower GI problems. So Dr. Dan Luba, Gastroenterology Associates, the number's 831-375-3577. 3577. Okay, excellent. So, Dr. Luba, let's continue our discussion. We're talking about colonoscopy, and I've got 101 questions. So, who needs a colonoscopy? When should they get their first one? Is it covered by insurance? How long does it take? How often do they get them? That's a good start, right? So who needs colonoscopy? When do they get them?
Pretty much everybody needs colonoscopy, and you start getting them at about age 50. If you have a strong family history of colon cancer, you probably want to get it earlier, probably starting at age 40. But you want to get a colonoscopy because we can find polyps, we can remove the polyps, and decrease your risk of getting cancer.
Now, Dr. Luba, now see, that right there is worth the price of admission alone. My previous guest, Dr. Hugh Wilson, we talked about that some people make polyps the way some people have moles, and some people have fatty tumors. We call them lipomas. But the issue in the colon is some of those polyps that are benign can become cancerous. Isn't that true?
Mm-hmm.
Now, Dr. Luba, I have an important question that I'd actually like to know the answer to this. Is it a polyp, just a typical run-of-the-mill polyp that can degenerate and become a cancer, or the polyp or the cancerous growth actually starts as a totally different type of growth? In other words, does a cancer just start to grow, or is it a normal polyp that degenerates?
No, with colon cancer, it is a polyp that then changes into a cancer. So what happens is you have normal cells, they get a couple mutations in those cells, and they start to grow. Those are precancerous. They're not cancers. If you get a few more mutations after that, then that polyp can turn into a cancer. So just because you have a polyp does not mean it's going to turn into a cancer, but if that polyp gets a few more mutations, then it can change into a cancer. So if we find it in the precancerous stage and remove it, it's gone.
Okay, so that's very important information to transmit to our viewers. Let's back up a second. We talked about chronic inflammation leading to probably more polyps and possibly colon cancer. If those conditions are treated, we talked about treating reflux, we talked about treating heartburn, we talked about treating ulcers. If you properly treat ulcerative colitis, Crohn's disease, those conditions that may lead to chronic inflammation, can you decrease the incidence of colon cancer?
Yeah, in those populations, yes. It's where if you have a lot of inflammation, you're going to have a higher risk of getting cancer. If the condition is well controlled, they do better.
Okay, so can we talk about briefly why people get colon cancer, for example? It seems like it's pretty common. As I said before in a previous segment, a brain tumor is pretty rare, fortunately. Primary bone cancer is so rare. But colon cancer, or a cancer of the GI tract, we hear about it pretty frequently. Isn't that true?
Yeah. Well, colon cancer, there's a lot of cells. They divide, they turn over, they're exposed to a lot of things in the environment when we eat, a lot of waste, and you can get a mutation in a cell. If you get multiple mutations, then you can develop a cancer. So that's I think why we see them so frequently in the colon. It has a high propensity to develop cancer. But like, for example, the small intestine generally doesn't get cancers. Not totally clear why that is. But most of the cancers occur in the colon, and we can find them.
Okay. Now, Dr. Luba, I know you're an expert in gastroenterology, and you have a project that you're disseminating or spreading the word about. Isn't there a genetic predisposition toward developing certain cancers in the body, and it's in certain populations or certain families' chromosomes, it's in their DNA, that they're more susceptible to developing cancers? Isn't that true?
Yes. If you think about cancer in general, 90 to 95% of cancer is what we call sporadic. So in other words, it just happens. People have bad luck for whatever reason, they get that. But 5 to 10% of cancers are actually genetic or hereditary. And when I was training, and up until 5-10 years ago, we were sort of taught that these were rare, and they're still taught that it's rare. But if 90 to 95% of cancers are sporadic, that means that 5 to 10% are caused by a genetic predisposition. Now, 38% of the population will develop cancer, and we're not talking about skin cancers then. There are about 380 million people in the United States. If 5 to 10% of cancer is genetic, that means that about 1 out of every 25, because 38% of the population will get cancer, that means that about 1 out of every 25 to 1 out of every 50, or 2 to 4% of the population, has a genetic predisposition to getting cancer. There are certain mutations in genes that can be transmitted from generation to generation, and they're at a very high risk of getting cancer. That translates to about between 6.5 and 13 million people in the United States. So when we thought about this stuff as being very rare, that rare number is 6.5 to 13 million people, or 1 out of every 25 to 1 out of every 50 people. That's not rare. And that's why I started Project DNA, which was basically a nonprofit corporation to change the system so that people can be systematically identified. So in other words, whenever you go to see your doctor, they can ask you questions like, do you have a family history or personal history of colon, uterine, ovarian, breast, or pancreatic cancer? It's 5 cancers. And those are really the big 5.
Okay, now Dr. Luba, those are amazing figures and facts that what I think we need to emphasize. So you said about 38% of the population will develop a cancer.
Right.
Isn't
Doesn't
it?
mean they're going to die from it, but they'll get a cancer.
Well, that's incredible. 38% of the population will get a cancer of some type. That's amazing. And did you say that about 5 or 10% of those cancers have a genetic predisposition?
Right.
Okay, so if we look at the Central Coast, well, let's look at Monterey County, 350 to 400,000 people, give or take, right? So that means there's going to be a significant number of those 350,000 or 400,000 people who will develop a cancer every year. And some of those will be, let's go over that list again: colon, uterine, pancreas,
Breast.
Or ovarian?
Yeah.
Okay. Okay, so colon cancer or pancreatic cancer or breast, we said.
Uterine and pancreas.
Uterine and pancreas. Okay, well that's amazing. Okay, so getting this word out I think is really vital, and I think what you're doing is really virtuous. So let's emphasize a couple points. So we know that there are certain populations, certain families are predisposed to developing certain cancers. And that's what your project is about, Project DNA. And we know that colon cancer, for example, when it's caught early and treated, it's 100% treatable, curable. Isn't that correct?
Correct.
And now, I want to talk about colonoscopy, and let's take a couple of minutes to talk about other ways to screen for colon cancer. So we know that what we want to do is catch colon cancer early, because
Or catch it before it turns into a cancer. So we can prevent it by taking out a polyp in the precancer stage, or catch a cancer before it's spread. I mean, those are the 2 goals. But really, we don't want to find the cancer, we want to find the polyp, because it's precancerous, and then prevent somebody from even having to go through having the diagnosis of cancer. That's really the goal.
That's worth the price of admission alone right there. So the colonoscopist or the gastroenterologist is not only looking for cancer.
No, I hate when I find that. That's the worst thing to find.
Okay, so see, this is worth the price of admission alone right here. This is so vital in terms of public health. So really what you want to do is find polyps. You're screening for polyps. You take the polyps out. We send them to somebody like Dr. Wilson. You send them to the pathologist. They're examined, and we want to get them out before it becomes a cancer.
Correct.
So that's an amazing effort on behalf of public health. So, okay, so how do we diagnose polyps and cancer early? There's a lot of different ways, right? There used to be, well, there still is. There's a barium enema. The radiologist can do things. We can do, we swallow barium, and there's the or the barium enema. There's GI follow-ups. There's something I keep hearing about called Cologuard. There's colonoscopy. There's the sort of hematest, right? Sometimes I think you can get at the pharmacy. You can get a little strip and test if there's blood in your stool, etc. So Dr. Luba, let's take a couple minutes and go through those, and I need to get you on another segment as a guest. Let's go through those testing types
Sure.
to screen for blood in the stool or colon cancer or polyps, etc. How about what the radiologist does?
So the barium enema, which is what the radiologists do, has sort of fallen out of favor as a screening test. So we're not really doing that very much at all anymore. There is a virtual colonoscopy that the radiologist can do, and that sort of has mixed results. It's somewhat difficult to do, although we can do basically a CT scan and look at the colon and see if there are polyps, and if then there are polyps, then those people can go back and get a colonoscopy. We tend to do that for people who can't get a colonoscopy. For technical reasons, they weren't able to get it completed. One of the other tests is a FIT test, where you're looking for blood in the stool. Basically what we're trying to do is we're trying to take the whole general population that's at risk for getting cancer and narrow it down to people who are at higher risk, and then have them get a colonoscopy. So a FIT test will look for blood. If there's blood in the stool, they get a colonoscopy. If you do the Cologuard test, that's looking for blood in the stool as well as some abnormal DNA. And if you have a FIT test, again, that suggests that if that's positive, they're at higher risk of having polyps or cancer, so they go for a colonoscopy to see if there are polyps and then remove them. And then the last thing you can do is just go straight towards a colonoscopy and just look and do the procedure, see if there are polyps. If there are polyps, then remove them. All of them ultimately lead to a colonoscopy where we can identify the polyps or the cancers, remove the polyps, or if there's a cancer there, identify it at hopefully a stage that can be treated.
Okay, great. Now, let's back up just for a moment, Dr. Luba. I hear a lot about, on television and magazines, Cologuard. What's that all about?
So Cologuard tests for two things. It tests for blood in the stool, and it tests for abnormal DNA. So if it's positive, then the people are referred for the colonoscopy. So basically, it's about 92% sensitive for finding cancer, and about 62% sensitive for finding polyps. So if there's a cancer, chances are the Cologuard is going to find it. If there's a polyp, it may or may not find it. But again, it's just a way of narrowing the field down to say, you know, who should go to get the colonoscopy. And, you know, for a lot of people, they'll say, I'm just going straight to the colonoscopy because, you know, you may not have a positive FIT test. You may not be bleeding at the time because polyps don't usually bleed. So it's just a way of narrowing things down.
Okay, so let's look at we said the population, just for the sake of discussion. In Monterey County is 400,000. So in terms of public health, we want our viewers to know that by the time you're 50, you should have a colonoscopy. Is that correct?
When you're 50, yeah, that's what's recommended.
Okay, now let's say they get a colonoscopy and it's not unremarkable, or it's normal, there's no polyps, etc. Well, actually, let's talk about two scenarios. Let's say you get a colonoscopy when you're 50 and it's normal. When do you get your next one?
10 years later, at age 60.
At age 60. Okay. Now, what if you do have a polyp and you have a polypectomy and it's benign, but you have a polyp? When's your next colonoscopy?
Depends on the size. So if it's a big polyp, we do it in 3 years. If it's a small polyp, we do it in 5 years. And the reason for that is I like to think about it as like fertile soil. So if you go look on the dirt and there's nothing growing there, you come back a year later, chances are there's not going to be anything growing there in a year either. But if you look at this piece of dirt and there's a whole bunch of weeds there, and you pull out all the weeds, you come back 3 months later, chances are there's going to be a bunch of weeds there again. So the people identify who have polyps, who have fertile soil, you need to do them more frequently.
Okay. And so starting at age 50, and then if it's normal, every 10 years. If you have a polyp, it could be in 3 years, could be in 5 years, depending on the size of the polyp. Now, for those families or populations that they know they have some inflammatory disease like ulcerative colitis, Crohn's disease, if they're treated, do they still get frequent colonoscopy, or do they just every 5 years?
Well, for somebody with ulcerative colitis, after about 7 to 10 years, they then start doing it every 2 years.
Okay.
Because there's still that inflammatory condition. Now, we have some medications that can not only just almost turn it off, and that may change the natural history, but we still don't have enough information to say we're going to just stop. But that may come out at some point.
Okay, so we have about a minute and a half left. Now, I'd want to talk about Project DNA, and again, in summary. If someone's interested in finding out more about Project DNA, where do they go? How do they find out more information? And what if they want to know, they're watching this program and they say, you know, my aunt had uterine cancer, and my sister had this cancer, and my uncle had pancreatic cancer. They want to get screened. Mm-hmm. And also, once again, I want to give out the contact information for Gastroenterology Associates, website and phone number, so people can call and get screened if they need to.
So Project DNA is a nonprofit corporation that I have. So the website for that is just projectdna.org. And if you go there and you have and you're concerned about your family history, you can go to Patient Tools, and there's actually a questionnaire. It's a computer questionnaire that you can punch in, and it'll tell you if you meet criteria for getting genetic testing.
Excellent. So projectdna.org. Anybody can look that up.
Right.
World Wide Web. Okay, excellent. Dr. Dan Luba, gastroenterologist. Now, what about the contact information for the Gastroenterology Associates? I may remember the phone number, but what about the website? Do you have a website?
We do have a website. It's just gastroenterologyconsultants.com.
Okay, perfect. And then my guys in the control booth, Michael and Dave, they're going to test my memory. 831-375-3577. Okay, 375-3577. Dr. Dan Luba, gastroenterologist. Dr. Luba, you're a great teacher. I really want to thank you for everything you do. This Project DNA is amazing, and you're going to help a lot of people. It's wonderful. Once again, this is the Doctor is in Television program. I'm Dr. David Morwood. I am a board-certified plastic surgeon right here on the Central Coast of California. Go to my website, drmorwood.com, DRMORWOOD, or call my office at 831-646-8661 for any information about any area of plastic and reconstructive surgery. Thank you very much, Michael and David in the control booth. I hope you will tune in again. Thanks very much for being here to the Doctor is in Television program.